everyone. We'll start in a minute. Please go ahead and fill out the demographic questions.
Welcome to the webinar, Dr. McComsey.
Great, thank you, Donna, and thank you everyone for joining us today. I want to welcome you to this. I guarantee you'll learn a lot from this. So welcome to this webinar. Before we start, we're just going to go through a few slides. My name is Grace McComsey, by the way. I'm from Case Western Reserve University, Cleveland, Ohio. These are the financial relationships of the content on the web board members. Next, you'll see the financial relationships of the presenter and myself and the planners. So this activity actually is accredited for CME. Next slide, whether you are a physician or nurse, pharmacist, you can get CME or equivalent credit. And for physicians, the AVIM mark points as well. Next slide. So we want to thank our supporters for this webinar, as shown here. And one important detail for questions, please submit your questions in the Q&A session. Feel free to chat during the session and discuss some of the content, but the questions will be taken only from the Q&A. So please remember that. And next, without further ado, I want to introduce you to our speaker. A lot of you probably know him, Todd Brown, a colleague and a friend, is a professor of medicine and epidemiology in the Division of Endocrine, Diabetes, and Metabolism at Johns Hopkins University, where he's also the primary endocrine consultant for the HIV clinic. In fact, Todd is one of few endocrinologists in the US who really have dedicated their career to endocrine in HIV population. He's a graduate of Columbia and Johns Hopkins, trained clinically at Georgetown and Johns Hopkins. His research has focused on metabolic, endocrine, and skeletal abnormalities observed in people living with HIV, particularly as it relates to aging. He served as the co-chair for the executive committee of the MAX-WISE combined cohort, and he's the co-principal investigator of the Baltimore/Washington site. He has also served in leadership positions on multiple clinical trials, including in the AIDS Clinical Trial Group, or ACTG, all related to the effect of antiretrovirals on metabolic and cardiovascular endpoints. He had mentored multiple trainees from across the nation and around the world as well, again, in the area of HIV, comorbidities, and aging. So without further ado, Todd, we're all looking forward to your talk. All yours.
Great. Well, thanks so much for the kind introduction, Grace, and thank you to IAS-USA for the invitation to come speak to you. So I'll be talking about diabetes in people with HIV, focusing on clinical aspects. As you know, it's a rapidly changing kind of landscape, and so I hope to give you an update on it. So here are my updated disclosures. Learning objectives, explaining how diabetes is different in people with HIV compared to people without HIV, and talking a little bit about antiretroviral therapy and diabetes risk. Talking a little bit about how people with HIV should be assessed for diabetes, and talk about considerations in diabetes management. So I'm going to start with the poll question, mostly to see how well the poll system is working. So the question is, have you prescribed diabetes medications at least once in the last 6 months? Yes, no, or I don't prescribe medications. Great. So a lot of people who do prescribe medications have prescribed diabetes medications. So that's great. So there are two pre-test questions using the same response system. This first one is with which of the following antiretroviral medications interacts with metformin such that with concomitant use, the dose of metformin should not exceed 1,000 milligrams daily. So it's doravirine, dolutegravir, TAF, or raltegravir. And I should say you'll be getting the same questions at the end. Great. Which of the following classes of diabetes medications is preferred for a patient with a history of heart failure? So sulfonylureas, thiazolidinediones, DPP-4 inhibitors, or SGLT2 inhibitors. Great. So I'll get to those questions at the end, give you the answers. So before I talk about diabetes, I thought I'd take a more philosophical approach and talk about life and my thinking about life and where comorbidities, a comorbidity like diabetes fits into it. So when we age, we think about the time that we have on the planet, so the quantity of life that we have, but also the quality of life. And as I think about my ideal life, it's to maximize the quality of life, including physical and cognitive function for the longest period of time. So this is how I'm thinking I want my life to go, that I have optimal quality of life until I die in my sleep at age 103, having spent the day in the woods with family and friends. So that's the ideal, but many of us, it's not going to go like that. So we experience declines in physical cognitive function and quality of life over time. And so when we think about this, then it's often stylized as sort of like a smooth curve like this, but oftentimes it's precipitated by events. So if you look at this person, they're doing fine, and then something happens to them. They have a heart attack, and they drop in their physical, cognitive function, quality of life, et cetera, don't regain it. Then something else happens. They develop heart failure. And then something else happens. They have a hip fracture, and that decreases the quality of life. And then something else happens, they have a stroke, and then they're much impaired compared to where they were previously. So the important thing here, and I think a really important take-home message when we think about comorbidities like diabetes, is that if we can prevent these events from happening, perhaps we can actually alter the aging process and optimize the quality and quantity of life. And so here's the argument. So prevention of comorbid events is really essential and achievable. So thinking about diabetes, we have good screening tests for diabetes, which we'll be talking about. Behavioral factors contribute to diabetes risk and definitely can be modified. Early treatment is very important once we do find it. And good treatments exist that can decrease the risk of having these events. And we'll be talking about some of those today. And this is the big part, is that preventing these complications and these events can alter the aging process, can really alter our experience. So let's talk about diabetes and why to care about it. So definitely super common with rapidly increasing prevalence around the world. It's the leading cause of cardiovascular disease, blindness, end-stage renal disease, amputations, and hospitalizations. It's very common in people with HIV, and in some populations, I work in the MaxWise, more common in the men and women with HIV compared to the men and women without. And importantly, and this is the need for these kinds of webinars, is that diabetes can be controlled, but the management is really quite complicated and requires individualization. So I'm going to talk a little bit about the pathogenesis of diabetes in people with HIV and how it's different. So like all comorbidities in HIV, you have host factors, antiretroviral factors, and HIV-specific factors. So the host factors, of course, are operative in any person, and adiposity is the major driver in people with HIV, just like people without HIV. And there are additional factors, of course, which may be contributing to adiposity and adipose dysfunction in people with HIV, including antiretroviral therapies, current antiretroviral therapies like integrase inhibitors, past antiretroviral therapies with their legacy effects like stabudine. Other co-infections may play a role, like hepatitis C, and actually curing hepatitis C may be important in improving diabetes. Genetic factors, of course, and then concomitant medications that may be more common in people with HIV, such as corticosteroids or atypical antipsychotics. The antiretroviral medication factors, so some of these are mediated, as I mentioned, through the impact on fat. Thymidine analogs and older PIs clearly have had a role and probably continue to have a role in people who had exposure to these even 20 years ago. Integrase inhibitors may have an independent effect on glucose metabolism. That's something that, and this is why I have a question mark next to there. Independent of their impact on fat. And then, of course, we know that there's residual immune activation and inflammation, even with an undetectable viral load. And this inflammation may impair insulin resistance even further, and also impair beta cell function. So I'm going to go over some key concepts for the management. The first is about screening. So how do we screen for diabetes? And before I do, I just want to give a shout out to the standards of care in diabetes. So this is published by the American Diabetes Association every January. This is the cover of the 2024 version. And I mention this because it's really a great resource. So many of the slides from the ADA that you'll see in the subsequent slides come from the standards of care. They do a very thoughtful job in going through all aspects of diabetes. So definitely keep this as a tab in your browser if you do take care of people with diabetes. So let's talk a little bit about the screening. According to ADA, these are the general groups of people who should get screened for diabetes: those who are overweight or obese with one or more additional risk factors. People with pre-diabetes should be screened to see if they've progressed to diabetes. Women with a history of gestational diabetes should be screened. And among other people, the ADA says that people with HIV should be screened preferentially, even without these other factors. So the general consensus, of course, is that HIV, people with HIV have an increased prevalence and incidence of diabetes. So how do we screen? So we generally have 4 ways of doing it. One is the fasting plasma glucose greater or equal to 126. And then the second is with an oral glucose load. So this is an oral glucose tolerance test, so 75 grams of glucose, and 2 hours after 200 or greater is considered diabetes. A random plasma glucose of greater or equal to 200 with symptoms of diabetes, so polyuria, polydipsia. And the newest addition here, which is no longer new, it's probably almost 20 years old, is having a hemoglobin A1C 6.5 or greater. Now, a few things. All of these should be confirmed with repeat testing, just to be sure that you don't have a lab abnormality. And the nice thing about hemoglobin A1C is that you don't need to be fasting. So it gives you an idea of what the glucose has been over the 3-month previous. And so it has a lot of benefits as a screening test. So here's the first ARS question. In a patient with HIV, hemoglobin A1C, A, underestimates glycemia, B, overestimates glycemia, and C is an accurate reflection of glycemia. So we have some split answers on that one. So we'll go over that. So when the ADA talks about using A1C for diagnosis, they say in conditions associated with an altered relationship between A1C and glycemia, only plasma blood glucose criteria should be used to diagnose diabetes. And so here are some studies looking at the relationship between A1C and glycemia in people with and without HIV. So this one, you see A1C on the x-axis, glucose on the y-axis. You have the dotted line here, who are people without HIV, the solid line, people with HIV. So if you look at, say, a glucose of 150, the A1C in that corresponds is about 7.5 in the people without HIV. The people with HIV, it's more like 6.5. So this is one of the first bits of evidence that there is underestimation of glycemia in people with HIV. So we also looked at this in the MAX. We had fasting glucose on a large number of people, men with and without HIV. You can see that we switched the axes because actually A1C is the outcome measure. And so as you see, as in the Kim study, there is a relationship between glucose and A1C, which makes sense. But you also see that there is a difference. And in our study, instead of having an A1C difference about 1 A1C percentage points, at 126, it was 0.2, so less than. But what you see is that after 126, so with glucose higher than 126, that difference actually gets bigger. Granted, there's more sparse data, but that interaction is statistically significant. And so there is likely a difference by HIV serostatus in how accurate hemoglobin A1C is. And when we look, we looked at factors that may be associated with it. And I have another ARS question about this. Which lab test is correlated with greater discordance between hemoglobin A1C and glycemia, I should say, in people with HIV? So alkaline phosphatase, AST, hematocrit, or mean corpuscular volume. Okay. So we looked at various factors that are associated with a discordance, which we think is clinically significant, so about 0.5 hemoglobin A1C points. And the HIV-specific factors that were associated with this discordance were having a lower CD4 cell count, being on a bacavir, being on a protease inhibitor, having uncontrolled HIV. So all those are important. But really the one that I use clinically and I think sticks out is the mean corpuscular volume. So how big the red cell is. And so you can see that with each 5 femtoliters over 80 that you have, or 85 that you have in MCV, you see a graded increase in this discordance, such that if you have big red cells, so at 105 MCV or 105 or greater, it's very high odds that there is this clinically significant discordance. So I think that this is an important take-home point, trying to figure out there is a lot of heterogeneity in how much discordance there is, but the MCV, which is often overlooked, we get it all the time, but is often overlooked on our CBCs. We can use that to understand whether or not the person is going to have clinically significant discordance. And I've always wanted to prove this, but my hypothesis is that these larger red cells are taken out of circulation more quickly than normal sized red cells, probably by activated macrophages in the spleen. And as a result, the red cell lifespan is shorter, and therefore the A1C is less than you'd expect. So for diabetes screening in people with HIV, I tend to use the fasting glucose. If someone has pre-diabetes, you can consider using a oral glucose tolerance test, but it is quite cumbersome. You need to give someone a glucose load and have them come back 2 hours later. I generally avoid hemoglobin A1C for screening, but it is very convenient. So I will interpret it if it's there, and if it's elevated, so 6.5 or greater, then that person likely has diabetes. It's those people who have a hemoglobin A1C of 6.2 where you're not really sure, or even 6.1, 5.9. And so these would be, particularly in those people, Vacavir is associated with this discordance, low CD4 as I mentioned, PIs, and then high mean corpuscular volume. So according to the ADA, how often should you do screening? So screen for diabetes and pre-diabetes with a fasting glucose, starting antiretroviral therapy at the time of switching, 3 to 6 months after starting or switching, then annually thereafter. So after diabetes is diagnosed, what should be the next steps? And so lifestyle modifications really are key. So changes in diet and exercise with the idea of weight loss. And really the landmark study which shows the importance of this is the diabetes prevention program. So these are people who have pre-diabetes, of course, outside of HIV, pre-diabetes, and they were randomized to a few arms, but I show you the lifestyle and the placebo arm. And the lifestyle had 150 minutes a week. So this is, in part where our exercise recommendations come from, and caloric restriction. And the goal, it's important to note, is not a ton of weight. The goal was about a 7% weight loss. And that was what was achieved. And the important thing is with that amount of weight loss, there was almost a 60% reduction in diabetes in the lifestyle arm. So then this is, I think, is a really clinically important point, and I talk to patients about this all the time, that if they're 50 pounds overweight, they don't need to lose those 50 pounds. It's really a relatively small amount of weight that can lead to a clinical benefit. And so to chunk that up and makes it less overwhelming for people and more achievable. The other really important thing that has come out in the last few years, or the last 10 years really, is not only how important physical activity is, but how important sedentary activity is, independent of physical activity, in various risks, including glycemic control. And so this is a position statement from the ADA. Telling people to stand up. You can be very active, but really prolonged sitting is a problem. It's something that we all need to watch out for, and to beware of the chair, as the sign says. So what about the first line drug when we talk about lifestyle modification? Really, these things should go together. Now, for a long time, there was a undisputed king here. And this is metformin. So metformin was considered the first line drug. And, rightfully so, it's a good drug. It has lowers hemoglobin A1C by about 1%, very long track record, no hypoglycemia, which is a problem of some of the other drugs, no weight gain, maybe even a little weight loss, a suggestion of cardiovascular benefit, very inexpensive. But there are some cons. So GI side effects can be a problem. We start low, 500 milligrams, and go up slowly over about a month. But it's treatment limiting. These side effects, mainly diarrhea and GI upset, in about 10 to 15% of people. The most feared complication is lactic acidosis, but fortunately very rare. And all the complications or contraindications are related to those populations that are higher risk for lactic acidosis. So people with chronic kidney disease, hypoxemia, decompensated liver disease, severe congestive heart failure, alcohol abuse, and past lactic acidosis. Now, over the last 10 years, it's been recognized that we were unnecessarily limiting people who have a moderately decreased GFR from metformin. So now the recommendation is that it's okay for people who have a GFR above 30. From an HIV perspective, and this gets to one of the questions, there is an interaction with dolutegravir such that concomitant dolutegravir increases metformin concentrations by about 80%. So 1,000 milligrams per day or 500 BID should be considered the maximum dose, particularly in people who have other problems that may increase the risk of lactic acidosis, such as CKD. So someone who has, say, a GFR of 45, that's the person in whom I'd be particularly, looking particularly at the dose of metformin. So, and you can see when you look at the ADA and the recommendations, this is from 2015, that really metformin is at the top of the list. In addition to lifestyle, metformin should be the way to go. So something interesting happened, in the time since, and quietly in 2023, there was a coup in that metformin, the reign of metformin ended, and it was no longer recommended as the first-line drug by the ADA. And so what does it look like? So this is where we are in 2024. This complicated chart comes from, and we'll be zooming in a second, comes from the standards of care, which I just showed you. But what I want to point out is the fact that their metformin is not at the top of the list here. And I'm going to zoom in on the left part here. And when we talk about first-line therapy, it really depends on what the patient in front of you, what kind of problems they have. And so the first consideration is that if they have cardiovascular disease or at risk of cardiovascular disease, and honestly, that's most people with diabetes, type 2 diabetes are 55 and older is one of the risk factors. So lots of people have these risk factors. A GLP-1 RA, a GLP-1 receptor agonist, which we'll be talking about, is preferred as first line, with the SGLT2 inhibitor as second line. Even, but you could argue that SGLT2 inhibitors should be given as well. People with heart failure, SGLT2 inhibitors is the way to go, at least at the writing of this, and we'll be talking about that in a second. And with people with chronic kidney disease, SGLT2 inhibitors are the way to go. And so it's these new diabetes drugs that led to this quiet coup, displacing metformin from the throne. And so for the GLP-1 receptor agonist, the first approval was exenatide in 2005. And for the SGLT2 inhibitors, dapagliflozin came out in 2012. And there's been more and more data, and we'll go over some of that, just showing the benefits of these drugs over other strategies. So let's talk about GLP-1 receptor agonists and talk a little bit about incretins, because this class of drugs are known as incretins, so it's important to know a little bit about the incretin effect. And so for a long time, it was known that the insulin response that you got was greater with an oral glucose load that you see in black compared to an IV glucose load. And it was thought that there was a hormone that was released by the gut that augmented or increased insulin response from the beta cell with an oral glucose load. And you can see that extension of this is that the incretin effect is reduced in people with type 2 diabetes. So it was found that there were a few hormones that played this incretin role: GIP, which is released in the small bowel; GLP-1, which is released in the distal small bowel and the large bowel by endocrine cells there. And these, so active GIP and GLP-1 have multiple effects. They increase insulin secretion from the pancreas. They have effects on the brain, increasing satiety and decreasing appetite. They slow gastric emptying and also improve liver insulin resistance. And so these drugs, these hormones, I should say, are rapidly broken down by an enzyme called DPP4. And this DPP4 is a strategy, inhibiting DPP4 is a strategy to prolong GIP and GLP-1 to have these benefits. And the drugs that we'll be talking about, these receptor agonists, are not broken down by DPP4. So they can be given weekly as semaglutide, dulaglutide, and now tirzepatide are. So the GLP-1s, endogenous GLP-1 has effects, as I mentioned, on enhancing insulin secretion, but in a glucose-dependent sort of way. And this is really a beauty of these drugs, in that unlike a sulfonylurea, which will release insulin from the pancreas no matter what the glucose level is, the glucose level needs to be high for the insulin release to happen. So this is really important when we're talking about the risk of hypoglycemia, and also importantly using these drugs in people without diabetes, which of course is a major population for the use of these drugs in obesity without diabetes. They decrease glucagon secretion. Glucagon, of course, opposes the action of insulin. The decreased glucagon reduces hepatic glucose output. They slow gastric emptying and have this important effect on central appetite regulation. We talked about some of the effects, but these GLP-1 receptors are located in many parts, many different cell types in the body, and this has been fascinating biology. We talked about the pancreas and the stomach and the brain, but in the heart and blood vessels, you see GLP-1 receptors in the kidney, on immune cells, in skeletal muscle, in adipose tissue, and in the gut itself. So these drugs do a lot of different things to a lot of different organ systems. And so this is in part gets at how widespread their benefit has been. So the first drug that came out in this class is called exenatide. So I show you a picture of the Gila monster here, because this exendin-4, it was first isolated from the saliva of the Gila monster. It has GI side effects, some mild weight loss. It was given twice a day. And as I mentioned, approved in 2005. And here's the initial studies from this. So here's hemoglobin A1C on the left. So an impact on hemoglobin A1C at the higher dose, about 0.8. Loss in weight, clearly different than placebo, about 2.8 kilos. But this was really the first of these drugs, and the subsequent drugs have been much improved. And here you see the various drugs that have been approved in this class. You see exenatide up at the top. Dulaglutide and semaglutide are the GLP-1 RAs that are used most frequently now, and you can see the hemoglobin A1C effect is much bigger than you see with exenatide. The weight loss effect for the dulaglutide and semaglutide is also greater than what we saw with exenatide. And there's a bit of variation in the weight effects, but it is very clinically significant. And the impact of this, I talked about the direct impact on the hypothalamus and feeding centers. This is a complicated diagram, and there's a lot of, as you can imagine, research that is going into trying to understand the weight effect. Interesting, I told you that GLP-1 is rapidly broken down by the time it gets to the liver, and only a small proportion of GLP-1 actually gets to the hypothalamus to regulate weight. Some of the weight effect actually happens through the vagus nerve. So with these vagal afferent nerves, which also have an impact, go straight up to the hypothalamus and have their impact that way. The weight effect and the glucose effect, there's no question, have been really amazing, particularly with the latest generation. But what has garnered the most attention with these drugs in the diabetes world, I think, is their impact on cardiovascular events. So in here, you can see in the last column that I added here that liraglutide, dulaglutide, semaglutide all have been shown to have a significant benefit in terms of their effect on coronary artery coronary events. Now, there are a bunch of different mechanisms. Some of them are systemic effects, so impacts on the liver, impacts on adipose tissue, impacts on the vasculature. Within the myocardium, there is direct GLP-1 receptors on myocardial cells, on arteries within the heart, and of course on immune cells, which I mentioned previously. The latest of these drugs to be approved are actually dual incretins. So they're GLP-1 receptor agonists, but they're also GIP receptor agonists. And so this is tirzepatide. And here you can see that dose-finding study looking at various doses of tirzepatide. Tirzepatide 15 is what's used in clinical practice as the highest dose. And this is compared to semaglutide 1 milligram, which actually is a little bit of a lower dose. We go up to 2 or 2.4 for obesity. But still significantly different than semaglutide 1 milligram for tirzepatide 15. And here are the effects on weight. And so here you see the semaglutide 1 milligram at 6 kilos, and about double that for the 15 of tirzepatide. So really potent effects. Now the MACE studies, the cardiovascular outcome studies, are not available yet. They're still ongoing. So let's talk a little bit about GLP-1 receptors and the pros and cons. I actually had to shrink the font on this to just now to fit in some extra pros, which data just came out. So good hemoglobin A1C lowering, about 1.5%. No hypoglycemia, which I mentioned because of that glucose-dependent insulin release. CVD benefit, like we talked about, weight loss effect on liver fat. The FLOW study, which was just published a few months ago in the New England Journal, shows that it preserves renal function in people with diabetes and impaired renal function proteinuria. So a really important strategy here. In the SELECT study, which is people with obesity without diabetes and heart disease risk, a history of heart disease, I should say, improved heart failure outcomes in people with both diastolic and systolic dysfunction. Improves physical function, and it's dulaglutide and semaglutide are weekly administration. So problems, nausea is of course an issue. This is why we start a low dose and go up very slowly with monthly increments. Pancreatitis is a concern. I generally steer clear in people with a history of pancreatitis. There is a decrease in muscle mass, and this is really quite interesting because there's improvement in physical function. So that really needs better understanding, particularly in older patients where we know that muscle mass is decreasing anyway. The cost, of course, can be prohibitive, and of course, the availability has become a real issue with the popularity of these drugs. It's been really hard to get these drugs for people, even people who've been on them for a long time and who have, insurance approvals, et cetera, to be on them. The data in people with HIV is relatively limited, and there have been 2 studies that have been published, and both of them are people without diabetes. But I wanted to show you the data just because these are the data that we have available. This is a study that I was involved in, led by Jordan Lake and Christine Erlinson, which was just published. It looked at its effect on liver fat. So the outcome was IHTG, intrahepatic triglycerides. So it took people who had liver fat with central adiposity and either insulin resistance or diabetes. And you can see the dosing scheme here going from SEMA 2.5 up to a maximum dose of 1 milligram. Generally quite tolerated. So this was single arm. And you can see the population, decent split between males and females. As you would expect, the waist circumference was high in that they needed to have an elevated waist circumference. This is the primary outcome. This is the change in hepatic triglyceride, intrahepatic triglyceride content as an absolute, which is a percentage, about a reduction about 4.2, or relative change in the percentage change is 31% decrease in intrahepatic fat. Difficult with subgroup analyses just because it was such a small study, but it looked like, just from the eyeball test, that the effect might be bigger in women and Hispanic and non-Hispanic white participants and older people as well. When you looked at the body comp outcomes, so you have BMI, weight, and waist circumference, of course, all significant. The weight change was about 7.8 kilos on average with the 1 milligram of semaglutide. So this study was designed at a time when the 2 milligram or 2.4 was not available. The other study was led by our moderator, Grace McComsey, just published in Lancet. Allison Eckert's the first author. So little bit of different population. This is people with central lipohypertrophy. And again, going up to the 1 milligram dose of semaglutide. This one had a placebo arm, which obviously is important. And you can see very significant reductions in visceral adipose tissue, some reductions in subcutaneous adipose tissue, now which may be of concern in people with lipoatrophy. It should be noted that people with severe lipoatrophy were excluded from this study. A body weight reduction about 10%, and lean body mass decrease, just like we saw in the studies in people without HIV. Allison Eckert presented this at CROI this past year, looking at inflammatory markers and the impact of semaglutide. And what you see is 40% reduction in CRP, 18% reduction in IL-6, significant reduction in soluble CD163. So all important inflammatory markers. Interesting, these weren't correlated with the changes in fat. So this might be indicative of this direct effect on the immune system that you see. So in people with HIV, because there is immune activation, there may be specific benefit to these drugs on decreasing systemic inflammation. So I mentioned the other strategy here are DPP-4 inhibitors, and there are some pros and cons to this effect. To these drugs. No hypoglycemia, weight neutral, so it doesn't have the weight loss effects that GLP-1 RAs do. There's some decrease in systemic inflammation. So there's a study in people with HIV showing that there's a decrease in soluble CD14. Relatively mild effect on glucose, but this can be helpful in people who just need a little bit of glucose lowering. Side effect, some GI side effects, but better tolerated than GLP-1 RAs. Some concern about pancreatitis. Some people have a hypersensitivity reaction. Unlike the GLP-1 RAs, there's no CVD benefit in the cardiovascular outcome trials. In fact, one of these drugs, there was an increased risk of heart failure. I didn't put it in, but this was a question that some people had about interactions with antiretroviral therapies. So one of these drugs, saxagliptin, is metabolized by CYP3A4, and so people who are on protease inhibitors or cobicistat should avoid it. They are expensive as well. So let's switch gears to the other class of drugs that is relatively new and has particular benefits. And these are the SGLT2 inhibitors, or the gliflozins. This is a cartoon of the nephron, just showing you what SGLT2 is and where it acts. So glucose is freely filtered by the glomerulus. It flows down into the proximal tubule, and most of it's resorbed by SGLT1. But some of it is resorbed by SGLT2. And so what these drugs do is block the SGLT2 such that you get glucose in the urine, and this the way that these drugs work, insulin independent type mechanism. The cardiovascular outcome trials and subsequent trials really show the benefits in terms of kidney disease. And so this study particularly looked at the effect of on worsening nephropathy. So there was about a 40% reduction in worsening nephropathy in people with diabetes. And you can see that the separation of the lines here between empagliflozin and SGLT2 inhibitor and placebo. These drugs decrease cardiovascular events. About a 15% reduction in the study, and you can see that the number of people who have these events over the study period is lower in the empagliflozin arm versus the placebo arm. And these drugs are particularly important for heart failure, and heart failure in people without diabetes, but also heart failure in people with diabetes. And this is heart failure with reduced ejection fraction and also heart failure with preserved ejection fraction. So this has really been revolutionary for heart failure cardiologists to have an important arrow in their quiver, which is the SGLT2 inhibitors. There are multiple potential effects, and this is a very hot area of research to try to understand some of these systemic effects of SGLT2 inhibitors, which may be improving heart function, and some of the direct effects on the myocardium that SGLT2 inhibitors may have. So here's an ARS question. Which side effect is the most commonly seen with SGLT2 inhibitor treatment? Okay. And so let's show the pros and cons here. So on the pro side, no hypoglycemia. So again, another benefit of these drugs. Some mild weight loss, not to the extent of the GLP-1 RAs, but about 2 to 4 kilos. Lowers blood pressure. So these in yellow are the ones that I highlighted. So preserving kidney function, decreasing heart failure risk, and decreasing cardiovascular event. They have relatively mild A1C lowering properties, but this is the side effect. That's the real problem. And so, these drugs increase glucosuria and provide a nice environment for bacteria and yeast to take root. And so for that reason, there is an increased risk of UTI and candidiasis. There's some concern about polyuria and dehydration. They do increase urine output. Concern about DKA in both patients with type 1 and type 2 diabetes. Some concern about bone fractures, although it's controversial. The canagliflozin, which is one of the gliflozin trials, had increased risk of amputations, and so that's some concern. And these drugs are indeed expensive. So when we think about after the diagnosis, the first line therapy and the combination therapy, sort of what other drugs, so just to round out the discussion, you're weighing the costs, the risks, and the benefits of these drugs. So sulfonylureas, which were very popular for some time, these drugs, as I mentioned, release insulin from the pancreas, no matter what the glucose is. They lower hemoglobin A1C, long track record. The drugs have been used to establish the fact that glucose control is a good thing, and they decrease microvascular events. They're really quite cheap. The problems, of course, are that they are associated with weight gain, hypoglycemia, which I mentioned, and they also have a high failure rate. The glitazones are interesting drugs. So these are PPAR gamma agonists. They have impacts on hemoglobin A1C, important ones, no hypoglycemia. They have an independent cardiovascular benefit and decreasing, improving dyslipidemia, decreasing liver fat. They may have a specific effects on inflammation, low failure rate. There is a modest effect on lipoatrophy, but probably not perceptible to most patients. And I used to have this in the cons, but with generics, they're relatively cheap. The problem, of course, are the off-target effects. So weight gain, and it's not only related to increased adipose differentiation and proliferation, but also fluid retention. And so we should avoid in people with congestive heart failure. There's some issue with macular edema, with osteoporosis and fracture, and an increased risk of bladder cancer. So these drugs are used, I think, not as much, mostly because of these off-target effects. Insulin, of course, is a really important strategy, and there are many different ways of giving insulin. We have an A1C, really an unlimited A1C lowering potential, decreasing microvascular events. The problem, of course, is the narrow therapeutic window. So hypoglycemia is an issue. Weight gain can be an issue. It's injectable, and of course, the costs, and maybe with recent government interventions, these costs have come down, but it's still a really important source of healthcare costs. Now, for starting insulin type 2 diabetes, this is what I generally do. I use bedtime insulin, so generally glargine or Dedamer, or NPH. I do sort of 10 units or 15 units, and have the person be checking their blood sugars and have them increase their insulin by 2 to 3 units every 3 days, trying to get their fasting glucose down below 120. You can add prandial insulin if the person can do 4 injections a day, and they're assuming they're eating 3 meals a day. Or sometimes I use in people who really can only do 2 shots a day. I do it's called a split mixed regimen, where you do 2 shots of 70-30, 70% the NPH and 30% the short acting, given before breakfast and dinner. So I generally, in order to reverse glucose toxicity for people who have very high glucose values, hemoglobin A1C above 10, I generally start insulin in that group, and I let people know that insulin's not a one-way street. So some people, you can reverse the glucose toxicity, you can get things under control, and then switch them to an oral or a GLP-1. The combination of GLP-1RA and insulin is a good one, so I use that quite often. And in people who have severe comorbidities, liver disease, kidney disease, that in whom you don't feel safe giving other drugs, insulin is the way to go. And people with very severe hypertriglyceridemia, insulin is definitely the way to go. So let's talk a little bit about the glycemic target. So for many of us, this has been sort of etched in our minds as the glucose target for an A1C less than 7. We, for a good reason, mostly because this is, if we can control things, we can decrease the risk of microvascular complications. In the 2000s, there were a series of studies, large clinical trials, which really looked at the question, okay, we know that a glucose, say, below 8 is a good thing. An A1C below 8 is a good thing. What if we try to normalize the glucose? And that's what these studies did. They looked at usual care, which was about an A1C of 7.5, versus like throwing the kitchen sink at people, getting their A1C down basically normal. And with the idea that, well, maybe we can reduce cardiovascular events. And here's a meta-analysis of those studies. So there was indeed about a 10% risk reduction for cardiovascular events, but there was no benefit on cardiovascular mortality. And so, as a result of the hypoglycemia that people got with throwing the kitchen sink at them, there was about a 2-fold increased risk of severe hypoglycemia in this intensive arm, which was targeting a hemoglobin A1C in the low 6s. And so this sort of changed our view of the glycemic target. Instead of A1C being where we should target everyone, we should individualize the target. So to have tighter control in sort of younger, healthier people that can potentially tolerate hypoglycemia, or looser control in people who are more hypoglycemia prone. And the addition of these medications, which were not in use in the 2000s when these studies were done, which had less risk of hypoglycemia, really have been a welcome addition to our armamentarium. So the question comes up, given the fact that I told you about the A1C decrease, or the A1C inaccuracy in people with HIV, should we be targeting a different hemoglobin A1C in people with HIV? And personally, what I do is I will probably target a little bit lower, but keeping in mind these individualization criteria. So trying to figure out, well, who's at most risk for hypoglycemia? Are they having hypoglycemic events? And trying to understand their other comorbidities and what's the risk of pushing them harder in terms of their glycemic control. And it should be noted that really the benefits with glucose lowering are at the highest. The difference between a 9 and an 8, for example, in hemoglobin A1C are quite a bit different than the difference between 8 and a 7 even, or 7.5 and a 6.5. So trying to get things down as close to 7 as possible, but you really have to look at the risk of hypoglycemia as well. So one of the tools that we've been using more and more are continuous glucose monitors. And I just want to talk to you a little bit about these. So I'm talking about the Libre system here. The Dexcom system is also excellent. There are a few others. So basically, these are sensors that are worn on the skin and changed every 10 or 14 days. And this is a reader that she's swiping over to get an instantaneous reading of her glucose levels. The newest ones go for use the cell phone, don't have a specific reader. But this is the report if you haven't used these before. So this is a period of 2 weeks, and this is a patient of mine. This GMI, this glucose management indicator, is sort of the equivalent of the hemoglobin A1C. So if this person maintained this glycemic control over a 3-month period, their hemoglobin A1C would be about 7.9. And so you can get a sense of where they are in their target range in the green, and what's high and what's very high. And you can also look at lows. And here's the overall gestalt. You can see this person comes in pretty good overnight, and then has this huge bump and then a decrease. And then importantly, you can look at every day what's going on. And so you can see the ups and downs that this person is having. So you can see, say, on this Tuesday, the 8th, very high glucoses overnight, and then they drop low here. And you can see the patterns as they go, and you can actually access this data in real time. So I'm often on the phone with patients looking at their glucose and saying, okay, what happened here on the 16th? Why did you drop down low? Trying to understand a little bit better what's going on. And we know that these CGMs work great in people with type 1 diabetes, and they're an essential part of the closed loop system for people who are on pumps. But in people in type 2 diabetes, they also work well. This is a study in type 2 diabetes with people on multiple daily injections over a 10-week period. And you can see that the people who had the reduction in hemoglobin A1C was much greater in those who got the Libre system versus the controls. So as far as what else should we be doing to preventing complications? So for the microvascular complications, yearly ophthalmologic screening for retinopathy, nephropathy, in addition to glucose control, there's blood pressure control, getting microalbumin every 6 to 12 months, using an ACE or an ARB for those with microalbuminuria, good lipid control, getting people on SGLT2 inhibitor. Neuropathy, doing foot exams once or twice a year, giving them good instruction for self-foot care, and if they have neuropathy, referring them to podiatry. On the macrovascular side, I use the ABCD approach, so antiplatelet therapy for those who've had a CVD event or who are at significant risk, generally above 20% 10-year risk. Blood pressure control, getting them on statins, diabetes and glucose management, smoking cessation, and getting people on GLP-1 RAs is really important as well. So in conclusion, a couple take-home points. A1C underestimates glycemia in people with HIV, so we need to use it with caution for diagnosis. Lifestyle changes are critical, so 5 to 10% weight loss really is doable for most people and not overwhelming. The newest diabetes medication have revolutionized the treatment of diabetes. So metformin is no longer always first line. So for people with CVD, generally GLP-1 RA, heart failure, CKD, and SGLT2 inhibitor. Although, as I put in these updates based on the recent data, so GLP-1 RAs also reduce heart failure, CKD progression. So are good strategies and as well and are good in combination. And SGLT2 inhibitors do decrease cardiovascular events. So individualized A1C as a goal, maybe a lower target in people with HIV, and we take a multi-prong approach to prevent complications. And so I'll just bring this slide back. So if we are controlling diabetes, finding diabetes, controlling diabetes, getting people on the right drugs, preventing those comorbid events from happening, perhaps we can bend this curve upwards and improve not only the quantity of life, but the quality of life as well. So I'll end there. I need to go to my questions. Which of the following antiretroviral medications interacts with metformin such that with concomitant use, the dose of metformin should not exceed 1,000 milligrams daily? So doravirine, dolutegravir, tenofovir alafenamide, or raltegravir. All right, 99% on the dolutegravir. Great. And so here's the explanation. I explained it during the talk as far as the impact, and this is through OCT2, and you can see the reference here. Second question, which of the following classes of diabetes medication is preferred for a patient with a history of heart failure? Sulfonylureas, thiazolidinediones, DPP-4 inhibitors, or SGLT2 inhibitors. All right, 96% on SGLT2 inhibitors. And I changed this. I said, you know, of the classes, because I used to have a GLP-1 when I've given this talk before in there, but then some recent studies came out, and you can see the refs here from the SELECT trial and from the FLOW trial, showing the benefits for heart failure. So GLP-1 RAs are also important strategies for heart failure as well. And we'll end there and do the question and answers.
All right, thank you, Todd. I can tell you, I mean, 99, 96, obviously you were very clear in your presentation, and we had a lot of good questions. So let me try to go over as many as we can. Couple quick ones, the interaction between antiretrovirals and GLP-1 receptor agonists. Is there anything to worry about there?
No. Yeah, so there's not really any interaction there.
Okay.
Yeah.
And then the metformin, dolutegravir. Should we worry about all integrase inhibitors? And specifically, somebody asked about bictegravir.
Yeah. So bictegravir increases it a little bit. It was never in the package insert. And so most people think it's okay. It does increase metformin concentrations a little bit. I'd be a little bit, you know, in that population that doesn't clear metformin as well, like the people with a GFR less than 60, I'd be a little bit, you know, maybe I wouldn't push the dose, you know, up to 2,000 in that population of metformin, who's also on bictegravir. But in general, it's dolutegravir.
And you showed data about what risk factors or what factors affect the discordance between A1C and glucose. Somebody asked about HIV viremia, knowing that what you showed, you know, most people were undetectable. So is there something there?
Yeah, so in our cohort, you know, in the max, those people who had detectable viremia, you know, did have an increased risk of discordance. It's always a little tricky because those people who have detectable viremia are a little bit different than those people who don't have detectable viremia. And so it's difficult to tease out some of those factors and to make a causal argument. So that is definitely a factor, low CD4. And I think trying to understand this and I think there's heterogeneous effects. You know, even people with the same risk factors may not have this discordance. So I think trying to understand this is really an important thing to do, because we use hemoglobin A1C. It's such a good test and a test that's easy to use. and interpret and readily accessible to the patient, it's a very good, I think it's a very good test, but we need to really understand it in people with HIV.
Perfect. So there were a couple of questions, very good ones on access, right? Everybody's having a hard time. So somebody asked for people with pre-diabetes, even when the BMI is very high, anything you can, do to increase the access and the insurance that's paying for GLP-1 receptor agonist?
Yeah. So the access has been a real problem. Anyone who prescribes these drugs know that they probably are getting, inbox messages, multiple times a week about I can't get my Trulicity anymore. I can't get my Ozempic anymore. So it's been a real problem. In general. And the companies, so Eli Lilly and Novo Nordisk, are sort of increasing capacity and making big investments to try to be able to relieve some of these backlogs. So that's one access issue that I hope, fingers crossed, are getting better. It feels like, just anecdotally from my Epic inbox, things have gotten a little bit better in terms of people saying, I can't get, I've gone to 5 pharmacies and I can't get my Ozempic. The other issue, access for people without diabetes, that is a problem. And I think insurance companies hopefully are sort of realizing that these drugs really do have significant benefits for some comorbid outcomes. And so the SELECT trial, which I alluded to, so this was in people with a history of heart disease who were obese but non-diabetic, very significant decrease in cardiovascular events in this group. So, this is important because cardiovascular events cost the healthcare system a lot. They decrease quality of life and increase morbidity. And so you want to decrease these things. And so at least in that population, I think that hopefully as more data come out, that people realize that there should be wider access. But it really is very insurance company dependent on how to get these drugs. The other related issue that comes up is compounding of these drugs, going to compounding pharmacies because of the shortages, people paying out of pocket. I generally, until there's more data to tell us that compounded pharmacies, have good product, I'm always a little bit nervous about recommending, and I basically don't. You just don't, these drugs are not regulated by the FDA, and you don't really know what's in them. The oversight of their manufacturing processes are not the same. So I personally would steer clear.
Absolutely. And one actually similar question, but a little different. Access to somebody who is on Ozempic, doing well, and suddenly they lose their insurance.
Yeah.
What to expect in terms of what you're gonna see with the weight, and anything you can do for these people?
Yeah, no, this is a real problem. So there is, when the drugs are stopped, they lose their insurance, their weight will come back. Whether other strategies might be helpful, other weight loss strategies on top of that. So people without diabetes, when we're talking about weight loss medications, whether some of the approved weight loss medications, but of course that person will be paying out of pocket for those as well, which aren't cheap. Sometimes you can get generic topiramate, which is cheaper. Phentermine's pretty cheap. So that's potentially definitely an issue.
And we had a couple of questions about people on hemodialysis, kidney injury. What are the preferred options? Insulin or DPP-4 inhibitors? What do you suggest?
Yeah, so I think insulin is probably the safest way to go. You can use a GLP-1 RA mostly for the impact on satiety. But I generally tend to use insulin in that group. DPP-4 inhibitors, I would steer clear from. They're contraindicated. You can use them at a low dose. So the dose, say, of sitagliptin is 100 milligrams. You can get down to the 25 milligrams, but they have a very mild glycemia lowering impact. And so I generally use insulin in that population.
Any data on GLP in MASLD or the old NAFLD?
Yeah, there is. And so there's definitely data that it decreases liver fat, just like we saw in Jordan Lake and Christine Erlinson's study, Slim Liver, that was presented at CROI. The big question is steatohepatitis. You can decrease liver fat, but do you decrease liver inflammation as well? And so I think that there's more data that needs to come out before we can use these drugs confidently. And as we know, there's a whole bunch of different strategies to decrease steatohepatitis that are coming down the pike. And where the GLP-1 RAs fit into this, I think they're going to be a component of this when we think about combined strategies, et cetera, but whether we're going to be taking a sequential approach or a combination approach is something that is going to be a really big topic, I think, in the next 10 years of medicine.
So somebody's asking you if you could comment on the need for bone density testing for people on GLP-1, or the combined GLP-GIP.
Yeah.
How frequently, if yes?
Yeah, I would probably stick to regular, guidelines. And so we recommend, in our recommendations that Grace was part of, we had people, suggested that people should get DEXAs in all postmenopausal women who have HIV and men 50 and older. Just because we know that the risk of fracture is higher in people with HIV. And I don't think necessarily that a GLP-1, being on a GLP-1 will have a specific effect. With the weight loss, of course, can decrease bone mineral density. And this is why, and really for whatever the reason is, it's important that people maintain physical activity as they're losing weight to mitigate the impact on muscle and to preserve muscle strength and thereby preserving bone strength as well.
So Todd, one thing that I've raised concerns about people with lipoatrophy, right? In our study, we saw whether you look at the DEXA, whether you look at STAT, subcutaneous fat by CT, we saw a significant decrease. And yes, we excluded people with severe lipoatrophy, but we know in our clinics we have a lot of people with lipoatrophy, but they do have a lot of visceral fat. So what is your position on GLP-1 receptor agonists in these people?
Yeah. I mean, it's something that we because we know that when we discontinue thymidine analogs, the fat comes back a little bit from your seminal work way back 20 years ago, but the fat comes back, but not anywhere near how much has been lost. And so we do have there is lots of prevalent lipoatrophy out there for people who are on thymidine analogs. And to add a medication that decreases subcutaneous fat, it's a relatively mild decrease in subcutaneous fat. And so it's tough to, whether it's clinically apparent is the big thing. And whether the benefits outweigh the risks. And it seems to me that the list of benefits, from the general population, what we're seeing thus far in people with HIV, that list is quite long. That would offset, a single percentage decrease in subcutaneous fat. But I agree. I mean, it's something that we need to watch out for, and we don't want to, add insult to injury.
Initial therapy for patients with very elevated A1C. So if you see someone, up front very high. Yeah.
So if they're obese and or overweight, I generally start with the assuming that insurance access is okay. I go with a GLP-1 RA and insulin. And then as you get and you can decide whether to do a split mix type thing, so 70-30 twice a day, or just evening insulin if they're sort of you feel like they can only do one daily injection. And as you reverse that glucose toxicity, and as they lose weight and you're ramping up your GLP-1, over time, you can potentially withdraw that insulin. And so this is where I have the discussion, hey, this is what we need to do now to get things under control, but this is not a one-way street. And we could potentially get things down so that you don't need insulin. The caveat here with the messaging is that there's still a lot of psychologic insulin resistance out there. And so people, think that, oh, my aunt, she got on insulin and then she got her legs amputated or she had a heart attack. And people think that there's a causal relationship here. Is that in reality, she had poorly controlled diabetes, and that's why she had these outcomes. And the insulin was, is a confounder there. And so, but these beliefs about insulin are really tightly held. And so I think it's important to really message the idea of insulin as a tool, and that it's different than before, and there's fewer peaks and valleys. It's easier to use. It comes in pens. So I think that minimizing or decreasing that psychological insulin resistance is really important.
Is there any association between CD4 and blood glucose or A1C?
CD4?
Yeah.
Yeah, I mean, in our study, people who had lower current CD4s had a bigger discordance. And my hypothesis is that has to do with increased immune activation and more active spleen macrophages taking these cells out of circulation. Haven't proved that yet, but that's my hypothesis. And so, yeah, so for a person, we all have these people in our clinics who have undetectable viremia, but who have persistent low CD4s. They haven't had an immune recovery. Those people we know have increased systemic inflammation. My suspicion is that group of people would also have a discordance.
Sounds good. Somebody's asking a question, and I've thought about complications of diabetes in people with HIV. Do they look like complications of diabetes and other diseases? Like
yeah,
cancer
it's an interesting question, and I don't think it's been well studied, actually. We know that, so on the microvascular side of things, so taking like the nephropathy and the neuropathy, we know that there are other reasons, and proteinuria, say for the nephropathy, we know that there are other reasons why people with HIV have nephropathy or have proteinuria besides HIV, besides diabetes and people. So it's a compounding factor. There's no question. Whether it's different in character, I'm not sure. Same thing with neuropathy, especially people who have been exposed to D drugs in the past, where they have neuropathy there. Does it make it worse if you have diabetes? Does diabetes neuropathy worse if you have been exposed to thymidine or D drugs and have neuropathy as a result? We think that the macrovascular disease might be a little bit different in people with HIV. Say that there's more non-calcified plaque, which is more prone to rupture. The diastolic dysfunction that you see that is related to HIV, that's something that's also seen in people with diabetes. And so it's an open question, I think, an important one. How much of it is it a qualitative versus quantitative difference? Are these problems different from a pathophysiologic standpoint in people with HIV, or is it just more of the similar thing that you would see in an HIV population without HIV that you see in people with HIV?
So somebody asked if you could elaborate on the risk of Fourier gangrene, the necrotizing fasciitis of the perineum with the SGLT2 inhibitors.
Yeah. So certainly a feared complication. Fournier's gangrene is really pretty severe. Fortunately, very, very rare. I think that like in anything in medicine, you're weighing risks and benefits. And so it's a very if you've seen one case, that is going to really change your perception of these drugs. But we always have to keep in mind, okay, this is a very rare complication. What we see more is the impact on on UTIs, for example, and which is and candidiasis, which was reversible if you stop the drugs. I mean, these horrible side effects like the Fournier's gangrene, fortunately they're super rare.
Last couple, do you recommend using fructosamine to assess glycemia?
Yeah, so fructosamine gives you an idea of what someone's glycemia has been in the last 2 weeks. I started when this came to light after Peter Kim and Colleen Hannigan's paper came out with A1C. I started doing that a lot in clinic with fructosamine. It gives you a little bit of an insight, but it's a different time window. And so personally, I don't do it anymore. Check fructosamine. Sometimes it can be helpful if you're really seeing discordances. Sometimes CGM can be very helpful. So in addition to having a therapeutic to have someone get a CGM, you can do diagnostic CGMs. You can give someone a CGM and they wear it for 2 weeks, and then you get the download. So go to your diabetes center, and they have CGMs that they can put on people, and so you can get a better sense of what their glycemia looks like. So that's another tool that I personally would use, because you get more information about where the peaks and the valleys are compared to just looking at fructosamine.
So Todd, could you comment on what's a typical follow-up schedule after you prescribe, whether GLP-1 or the SGLT inhibitors?
Yeah. I mean, I think that typically for these drugs, you go up at month-long increments, and sort of depends on the person. But I generally bring them back after they've gone up to the first dose, and what I do is I have them message me, through Epic after the third dose, and give me a thumbs up, and then I prescribe the next dose. And then, assuming they're going up, then I'll see them back, and it turns out to be about 4 months or so.
Another
really,
access.
the hardest part, a couple hard things about prescribing these drugs. One is get the availability, getting them, and so that can be a real challenge. And the second is just going up sort of slowly with these drugs. And some people, it's really, there's a lot of heterogeneity in response. And some people have a big benefit at relatively low doses. They just need to see a whiff of these drugs in order to have an effect on appetite, effect on A1C. Then there are people who get up to the highest dose, about 15% or so, and they don't see the weight benefit. They don't, usually 5% weight loss is what's considered clinically significant, and there are about 15% of people who don't meet that on either, on semaglutide, for example. And so why there's that heterogeneity, that some people are more responsive than others, I think is a really interesting question, and one that a lot of people are looking at right now.
So would you start GLP-1 receptor agonist on someone who has pancreatitis, history of pancreatitis, or with very high triglycerides?
The triglyceride question, I would use insulin first, and then if weight is part of it, I would use insulin first to get their triglycerides down, and control their sugars. Then maybe think about starting GLP-1 for the weight aspect. In someone with pancreatitis, I steer clear, actually, from GLP-1 RAs. A history of pancreas, you don't mess with the pancreas.
Exactly. So what medications do you recommend for people with alcohol use disorder?
For alcohol use disorder? Well, I don't think necessarily if someone has alcohol use disorder and they haven't had pancreatitis, that we should be steering clear. And there is some evidence, I think emerging evidence, that these drugs hit the reward centers. And so they're being investigated for alcohol use disorder and for nicotine addiction. So it's really, I think we're really just scratching the surface now on what these drugs do. But I think for someone with diabetes who has alcohol use disorder, unless if they've had pancreatitis, that's a separate thing. But I'm okay, with generally with prescribing. Of course, it's it's an individualized decision, and that's what makes diabetes management, as we were talking about before, both interesting and challenging, is that you really have to tailor your regimen to the person in front of you.
So how about oral semaglutide? That's a good question we get all
Yeah,
the
so
time.
oral semaglutide, is a so this goes by the name of Rybelsus. You might have seen advertisements for it. I've used it a bunch of times. It doesn't in the cardiovascular outcome trial. It didn't have a benefit, which is sort of a little bit weird. I tend to use the injectables, and some people just really don't like the injectable thing, or find a lot of people find the weekly administration, liberating, and they have to just do it once a week. They pick a day, it's not a big deal. Some people just find it disruptive, and would rather have something that they do every day. And so that's the group. I have done it in people who have had trouble getting their weekly drug because of availability. There seems to be more availability for oral semaglutide, and so I've switched people that way, as a bridge until their semaglutide or dulaglutide or tirzepatide becomes available.
So what is the role of diabetic diet and glycemic control in patients with diabetics? Diabetes?
Yeah, so there are two aspects of this. One is a diet that leads, a relative caloric restriction that leads to a weight loss, and so this is very important across the board for people who are overweight or obese with diabetes. Trying to get them down, about a 7% weight loss, as I mentioned, and caloric restriction is an important part of this. And not, going down to a very low calorie diet, but eating in a healthful way, restricting the calories around 500 calories a day, trying to cut out some of the high caloric things that they were doing before. So that's one part of it. The other part of the diet, looking at diabetes diet, is trying to reduce the concentrated sugars and the simple sugars in the diet. And you can see really, and people who have CGMs really can, look to see what medications really drive up their sugars, and they can see it, in black and white, what the trajectory looks like. And most often these are carbs that are really quite easily processed, and you get this glycemic spike. And it does make sense to make your carbs more complex. The simple difference between an orange and orange juice, say, is really pretty stark. So an orange juice gets absorbed absorbed pretty quickly. You get this big spike. Whereas even though you have orange juice, obviously in an orange, it takes time for the body to digest this. So the glucose excursion that you get with it is less of a severe spike. And so really looking at the complexity of the carbohydrates is important.
So how about continuous glucose monitoring system? People were asking if it's available through Ryan White, and regardless, should we use it more for primary care providers?
I've been using a lot of CGMs, and I think it's becoming more and more, in Maryland, our Medicaid is paying for it, particularly people with multiple daily injections. And it really helps people. They don't have to do finger sticks anymore, which is great. They can get a good idea of what their blood glucose is without having to prick themselves all the time. You can get the data, quite easily. And as I mentioned, you can, be on the phone with them and be looking at their data in real time, and talking with them about their data. So I think that there's increased recognition what an important tool these are in people, definitely patients with type 1 diabetes, no question about it. But even in patients with type 2 diabetes, especially those on more complicated regimens, it can be really helpful.
So Todd, GLP-1 receptor agonists, have they been added to the ADAP formulary? Do you know?
I don't know. I'm not
Yeah,
sure. I'm not
don't
sure.
either.
It's a good
All right.
question. I'm sure there, you know, I'd be a staunch advocate if there's any question, but because I think that they are really important.
Perfect. I'll tell you, we had an extra 15 minutes of questions. So I'm going to ask people, there are only a couple of questions left. If you want to stay on, Todd, just
Sure.
answer them.
Yeah.
That would be fine. So if people have other things to do, but I think, you know, having almost 150 people still when we're 15 minutes after the schedule, I think it says a lot about your talk. So I want to thank you and thank everybody for joining. Hopefully you learned a lot. So I'll leave Todd to answer those questions.
Great.
Thank
Thanks,
you,
Grace,
everyone.
and thanks everyone for tuning in. Let me, people want to stay on, I'll, what will it take for Medicare plans to approve GLP-1 for patients without a history of a cardiovascular event? You know, so there are two issues here. One is it people, and I'll just, there are some upcoming talks, and you'll see the announcements come up on the screen as I'm going through these questions. Yeah, so I think there is you know, increased evidence that these drugs have a benefit beyond just weight control in those with obesity, and in those with diabetes as well. So I hopefully the sands are shifting on that one. How relevant is microcytosis in overestimating A1C? It didn't seem to be a relevant factor in our study, but hasn't really been investigated as well. Do glycosuria and proteinuria key markers of proximal renal tubule dysfunction? Should we entirely avoid TDF where feasible in diabetics and those on SGLT2 inhibitors? I would say, so I think the TDF probably yes. For those on SGLT2 inhibitors, it sort of depends on the GFR. You know, most of the studies have looked at specifically at people with proteinuria, not so much with pre-existing glycosuria. But the nephrologists are getting more and more comfortable with these drugs, and there's not much in the armamentarium that can help. So there, and the risks are relatively low. So my feeling would be that probably yes. Metformin is transported by OCT transporters, amongst others, contributes to interaction with DGG. It may not be reaching the site of action effectively, so actually may work less. Are there any data? Not that I know of regarding the data. So yeah, it's difficult to say. You know, metformin has lots of different you know, actions on very many different cell types. And so, you know, you're always clouded by a case that you know, brought it out to you. I personally had a case of someone on metformin who was bounced up to a higher dose and developed lactic acidosis, someone with HIV and dolutegravir. So I'm a little shy, I'll admit, and a little more strict than a lot of people. But I think that the mechanisms, and I think people have backed off a little bit on the restrictions with metformin and dolutegravir. In those with impaired renal function, so GFR less than 60, I would definitely not go to the higher dose. And I think we answered the last question about ADAP formularies, and I think it's you know, it's a work in progress. See if there are any more questions.
Great. Thank you, Dr. Brown. Thank you, Dr. McComsey.
Great. Thanks so much, everyone, for your attention.